Introduce the next session, and this is going to be on patient-shared decision-making, which I think transitions really well, and the last panel really set the stage about why this is so important. And we have a fantastic group of speakers that I'm excited to get to also introduce. So the first is Dr. Abba Coleman, and she's an OBGYN with Baylor College of Medicine and Texas Children's. She actually was at Ben Taub for a number of years, and I got to work with her before she moved over to being the medical director of the center. And teaches a course that I have gotten to participate in that really changed the way I take care of patients and interact with patients and taught me so much. So I can't wait for her to do the same thing with all of you. She served as a facilitator for the Academy of Communication in Healthcare since 2016. And in this role, Dr. Coleman helped train providers through their institution's relationship-centered communication workshop, which is what I just referenced. In addition, Dr. Coleman has had the pleasure of assisting as a facilitator for several ACH or Academy of Communication in Healthcare external programs related to equity, diversity, and social determinants of health. And currently, Dr. Coleman is a faculty in training with ACH and looks forward to continued collaboration in healthcare communication. She is also sharing the stage speaking with Fumi Amole, who is the manager of advanced practice providers in the emergency medicine division at the West Campus for Texas Children's Hospital. And in that role, Ms. Amole manages a team of nurse practitioners and physician assistants who provide direct patient care to patients from 0 to 21 years old. Prior to joining Texas Children's, Amole was in private practice at Dickerson Pediatrics and began her career as a pediatric nurse at Children's Memorial Hermann as a graduate nurse. And she lived just outside of Houston with her husband and 2 daughters. And then also speaking with her, Dr. Christina Davis Cancanagay, who also was a resident that I had the pleasure of working with at Ben Taub. She pursued residency in OBGYN at Baylor College of Medicine, and while training to provide comprehensive, inclusive gynecology care for women, her interest expanded to providing reproductive health care to all females and led her to pursue a fellowship in pediatric gynecology in Kansas City at Children's Mercy Hospital. In training there, she used that opportunity to obtain her Master's of Science in Bioinformatics from the University of Missouri, Kansas City, and her master's thesis was on shared interest in complex contraception and an opportunity for practice improvement in the solid organ transplant community. And then finally, Natasha Bush, who is the Director of Nursing for the Emergency Center, Call Center, and Forensic Nursing Team at Texas Children's Hospital, where she's been a nurse for 16 years with experience in the pediatric ICU and emergency department. She graduated with her master's in nursing from Chamberlain University and began her career at Texas Children's as a staff nurse in the emergency center. In her 8-year tenure at Texas Children's, she's been involved with and led several quality initiatives and has been awarded the Shamrock Award and is the 2020 Catalyst Leader of the Year and lives in Baytown with her spouse and 2 children. So this very diverse, very prestigious group is going to now share with you their experience and their course in shared decision making. And I'll turn it over to you guys. Thank you so much.
Thank you very much. And just to make sure, can everyone hear me well? All right. Thank you very much, Dr. Epps, for your introduction. And thank you all for having us join you. It is such a tremendous honor to be part of this summit and to be able to share a little bit of the work that we've been able to do in the area of relationship-centered communication. And I do wish we could all be together in the same place, but we are excited to gather here on the virtual platform. And with that being said, there are a few opportunities where we're hoping to be able to interact with you all as well, a couple of exercises and activities. And we do encourage utilization of the chat box too, to try and make this as interactive and robust a conversation as we can. So with that, we'll move on to the next slide, please. And our objectives are fairly straightforward. So as you've heard multiple times in our introductions, we are committed to communication and excellent communication, particularly in the healthcare setting. So we'll start with some just foundational definitions. What does communication mean? And then we'll move on to exploring why communication really serves as a foundation for what we are going to continue discussing, which is shared patient decision-making. We'll take a moment to identify some common communication gaps and then introduce more about this relationship-centered communication model that we've mentioned. And then for a moment, encourage some reflection of our own communication styles, and then demonstrate how we can utilize some of those tools that come from the relationship-centered communication, which I'll refer to as RCC for the remainder of the program, but that's relationship-centered communication, how some of those basic tools can be used in some of our typical patient encounters. And as we'll see in the slide today, our goal is to provide a snapshot. And although we are described as performing a training, our hope is that you will take away some tools that you can put in your back pocket and utilize, from the care team perspective, and also from the patient perspective as well. So with that, we'll continue to the next slide. To define communication, why don't we just turn to the Oxford Dictionary, please? And defining communication there, it's considered the successful conveying or sharing of ideas and feelings. And I'll take the next slide. Why does communication matter? If you look at the foundations of shared decision-making, we've heard really, really amazing stories, and I cannot thank our panelists that just preceded us for being so candid and sharing your experiences. And I'm just reflecting on all that we've heard and thinking effective communication really does lead to partnership, leads to trustful, collaborative relationships. And from there, we move on to the next arrow, which is the shared goals, decision-making between the patient, between the care team, between family and caregivers. So that is the general roadmap, why we will take some time to focus on communication as a whole, but just keeping in mind this special slide here, how it's a continuum that with effective communication tools, open, direct dialogue, we've developed those partnerships and relationships, which form the foundation of relationship-centered communication. And I'll take the next slide, please. And as our two little friends show us here, communication is a two-way street. So we are giving information, we are receiving information, and through all of that, ensuring that the information is appropriately processed and received. And I'll take the next slide. But with that in mind, as George Bernard Shaw commented, the single biggest problem in communication is the illusion that it has taken place. And I'll take the next slide. So if we think of communication as a procedure, so as Dr. X explained, I'm an OBGYN, and I acknowledge that I will probably speak a little bit from that perspective, and we all bring our unique identities and perspectives to the table. So if I think in our day-to-day work, communication is kind of like a procedure. And in fact, at ACH, we really believe communication is a procedure. And if you consider it as such, then it really is the most common procedure in medicine. And I'll take the next slide. However, we probably receive less training in this. And if you think of procedures, patient interactions in your day, in a career, we estimate that that's more than 200,000 in a lifetime in a typical career. And we get less training, less practice, less feedback than other less common procedures. So again, if we look at this realm of communication as a procedure, we can learn these skills. We can learn skills, we can teach skills, we can continue to grow and develop, we can receive feedback. And if we think of it as any other skill, whether it's riding a bike, playing a musical instrument, doing an OR procedure, this is something that we can continue to get feedback and grow in this area. Mastery does require deliberate practice and feedback. And I'll take the next slide. So as an example, as I promised, we're going to try and be as interactive as we can here. And we are just going to do a little exercise that I think highlights how we think we are communicating and how others are hearing. And with that, I will pause and turn things over to my colleague. And I'll pause there, mute myself.
Thank you, Abba. Can everyone hear me okay? So as Abba mentioned, we think of communication as a procedure. And so we're going to try this out as a procedure. And for this procedure, I need you to get a piece of paper and a pen if you are close to one, so that we can make an attempt to do some communication. So the first thing I want you to do is think of a house. Just think of your fascinating house, a house that you would like, and we're going to try to draw this out just a little bit. I want you guys to know that I'm going to do my best to communicate all of the information to you. You're going to try to make every attempt to draw this house. I think that I'm being as clear as possible, but we'll talk about that in just a minute. There's not going to be an opportunity to ask me any questions, and then there won't be an opportunity to request clarification. So I'm going to give this information over to you guys, okay? So if you have your pen and paper ready, let's get started. So this is a one-story house. I want you to draw a square for the base of this house. And so I want you to add a front door to the right and a window to the left. Every house will need a roof. And so for the roof, we're going to do a triangle. And then every house should probably have a chimney. And so this house is no different. So we're going to put a chimney. Let's add one on the roof above the door. And if you're a gardener like me, the house should probably have a window box. So let's see what your house looks like. For my colleagues that are on the call, we're going to try to see what their house looks like. And I'm going to go to the next slide. Next slide. Awesome. Awesome, awesome. So does your house look like the blueprint? If you're savvy enough, if you can upload a picture of your house in the chat, that's great. If not, you can certainly put any comments in the chat. And then think about how this applies to our day-to-day. Are we as clear and concise as we want to be in our communication? And then in hindsight, what might I have done differently? Could I have talked about the color of the house? Could I have talked about the layout or the landscape or the direction of the house to help kind of make it a little bit easier? Could I have talked about kind of the scale of the door? I looked at Abba's and her window's a little bit smaller than where I would have liked it. Some are pretty close. Could I have talked about the fact that there's a dormer at the top? Again, we're just making sure that there is clear communication and be as concise and as articulate as possible. And so some folks have sent images in our chat. My colleagues are monitoring. Someone got very close. Wow. Great job, Melissa. Alicia said her doorknob was on the right side. And as you take a look at the drawings, there's some variations in the drawings, and that kind of represents our communication and how there are variations in the interpretation based on our delivery. And so I'm going to turn over to my colleagues on the next slide. As we talk about kind of our interpretation and the way in which we deliver information, what does that really mean? When we say, I'll be right back, does that mean in 5 minutes or 10 minutes? I need a little more detail. Have we elaborated on the details that we need? Let's trim that down. What parts would you like to trim? Just continue as we think about how we communicate. How can we be more concise with our communication? Next slide. So I'm going to turn this over to my colleagues.
So bringing things to the OBGYN setting, and again, I acknowledge and apologize that some of these examples will be, again, specific to what each of us knows best. So I'm using these examples because these are questions that have come up and queries that have come up from patients and families. And when you pause and you think of the words, it really does make you pause. So, you know, we recently had a patient who had a cesarean delivery and the following morning expressed concern about the fact that her but she had heard about her uterus being removed and replaced. So how often do we say during a cesarean delivery, you're just going to feel a lot of pressure, we're just putting the uterus back in? Well, where did the uterus go? And in this instance, what we, are often commonly are referring to is the way the uterus is positioned during a cesarean delivery at times for the closure. And if you think of the words, it really does sound like the uterus was fully separated and it is now being put back in. Or if we speak of gestational diabetes or pregestational diabetes, and sometimes as providers, we're a bit vague. Your blood sugar is a little high. Let's watch your carbs. Let's make sure you get some exercise in every day. And sometimes a patient or family member may not necessarily bring up the clarification that what is some exercise? Is it 20 minutes, 5 days a week? Your blood sugar, all the after dinners are elevated by 10 points. So just using very specific and deliberate language can be very helpful in many circumstances. And then ultimately the cervix is favorable or not favorable. Maybe we are discussing an induction or how close it seems, like a mom may be to labor, but we use terms and that might actually almost land very differently. Why is a cervix favorable or not favorable? So again, terms, just a few examples that we use day to day in the OBGYN setting that maybe we can pause and figure out ways to maybe be a little bit clearer in our language. So with these sorts of examples in mind, we've dipped into the OBGYN world, and obviously that applies to the neonatal and newborn world as well. And we have also used some examples from the business setting and general conversation. With that in mind, we'd like to share some of those tools that can help with clearer communication. And again, this is just a snapshot. This is the tip of the iceberg and giving a sampling of what relationship-centered communication is. And it's one framework and it's one model, and there are many. So at this point, I will turn to my colleagues to introduce some of the key aspects of RCC. So I'll turn things over to Fumi.
Thank you, Abba. Can you all hear me well? Great. So as we look forward into relationship-centered communication, I know, like Abba had mentioned, it is part of a framework. We've all probably heard some information about patient-centered communication in our different divisions and places of work. When we're looking at relationship-centered communication, I think our previous panelists mentioned it best. And Eric kind of pointed to the wonderful experience they had and how they were integrated into the healthcare delivery of their children. However, Judith's experience was very different, and she wasn't incorporated in there. So beyond the patient-centered, we want to look at the relational component of communication and that interaction. Next slide, please. And so this is a balanced engagement between both the patient, the caregiver, and the provider, the clinician. There is a desire for us to connect on a personal level, on a humanistic level, a willingness to understand each other's perspectives and ideas, and it does require empathy. I think one of the panelists spoke about how they were in the NICU so long they became friends with some of their nurses and care providers. It doesn't require always that we become friends, but it certainly does require mutual respect, mutual trust, which are foundations for every good friendship and every good relationship. And so when we're talking about relationship-centered communication, we really want to emphasize on that. Using empathic responses, both with verbal cues, and then I know now in this post-COVID era, our nonverbal cues are a bit limited, but certainly can still be impactful. And being creative around ways to incorporate that into the communication. And certainly meeting up at a mutual goal. So this mutual goal of better health and well-being for our patients, for our families, is important to really stress as we're focusing more on relationship-centered communication. So it's for the whole family care
not just the patient in front of you, but including everybody, because there are stakes. It's high stakes. Next slide, please. And so there are benefits in looking at research and studies that have gone ahead. Research using biopsychosocial model shows wide range of benefits as it pertains to the patient, as it pertains to the caregivers, but also at the organizational level. Next slide. And so with, for our patients, we know that it leads to better clinical outcomes. When we look at chronic illnesses such as asthma, diabetes, it just really changes the reduction of adverse outcomes with chronic illnesses. In addition to that, there is increased adherence to both medications and to treatment plans. I wonder how often we assume non-compliance from our patients when it really was just poor communication that led to that non-compliance. When there's decreased understanding, decreased or impaired understanding that leads to poor adherence, and that can actually be the reason for it as opposed to what we would assume as their unwillingness. With healthcare workers and providers and teams, next slide, studies have showed really just improved diagnostic accuracy. Actually, there was a study that showed that there were less tests being offered, fewer referrals to specialists, just because we received better, more concise, complete information from our patients. Our ability to gather a robust H&P is improved when our communication style is more precise and more deliberate. In addition to that, more information helps to, I guess, accuracy and the meaning of the information that we're gathering from our patients. So increasing all of those helps with the outcome for our healthcare providers. And if you guys are like me, I derive a lot of my job satisfaction from those meaningful interactions with our patients, when a patient just pauses and says, you know what, I really appreciate the time you took with me, or they're impacted by some way. And it's usually those families that we did find or make a meaningful connection with. And so with relationship-centered communication, we're looking at how can we optimize that with every patient encounter? How could we practice and use tools that are applicable to increasing those interactions? And of course, with that comes increased job satisfaction, so less stress, less burnout, and where there's increased trust, there's decreased medical malpractice. And so we want to make efforts to do that for healthcare providers. The next slide, we look at really at the organizational level, how does it affect organizations? And studies have showed certainly quality outcomes we alluded to before as far as patient safety, clinical measures and matrix that we monitor, but also at an organization level, I think is just more fiscally beneficial, right? You have the opportunity, reduced need for service recovery for poor patient interactions or poor patient satisfaction. There is less employee turnover, job satisfaction for your team members as far as the organization goes. And it becomes prudent for, at an organizational level, to improve the skill of not just clinicians, but every member of the organization in this style of this mode of communication as far as relationship-centered. Next slide, please. And so with that, I'd love to turn it back over to Abba just to talk about what we have had the opportunity to do within our organization at Texas Children.
Thank you. As Dr. Epson mentioned, we've been navigating the journey through an RCC model of care here at Texas Children since about 2016. And I just wanted to take a moment to share a little bit about our experiences, as we probably have shared experiences with many other people here on this meeting. And again, it started with a collaboration with ACH, and our curriculum, our workshop is about a 5.5-hour relationship-centered course that is comprised of short didactic sessions and then some skill set demonstrations, which is what you're going to see here in a little bit, and then some small and large group role play sessions. Now, I'm sure that when I mentioned role play, some people are smiling and some are cringing. Interestingly, you know, it's something that we've now been able to train over 1,500, and people do get into it. And honestly, it creates a safe space to be able to try out some of these skills and communication tools that may not be necessarily comfortable or innate in our training. And it allows us to get feedback. And what we do is work together as a team, and we provide feedback for each other in the course of this interactive session. And I'll take the next slide. So showing a timeline, I think we may have to click on it a few times for the timeline to show up. And we can click on them all through. So beginning in April 2016, we did some focus group work, basic needs assessments, then went through the Train the Trainer program, and then implemented training sessions. And as I noted, we've been able to train over about 1,500 at this point. And recently we were able to add a team of additional 8 new facilitators, and we are expanding for all of Texas Children's. And I'll take the next slide. And what we found in the pre-course and post-course survey that we do when it comes to self-efficacy and the learned skills of sharing, understanding, discussing a treatment plan, and closing encounters, we did see a statistically significant improvement before and after the course. So we are encouraged by what we are seeing and looking forward to the next steps. And as always, happy to share, you know, our experiences and compare notes. I'll take the next slide, please. So to delve a little bit into what the curriculum and the workshop looks like, it's broken up into 3 parts of typical encounters, and today we're going to focus just on one. So when a provider or caregiver or member of the medical or healthcare team first meets a patient or family member, that's the focus of skill set 1. How do we begin that encounter? How do we establish rapport? How do we create an agenda that we have negotiated, where all of those aspects that are important for both the patient and both the care team are addressed? Then the next part is the relationship-centered interviewing, where we open the conversation, foster dialogue, and really explore what the patient and the family's ideas, concerns, expectations, and perspectives are. And then we do what we do best, which is the data gathering, the typical exam. And then at the end, whether it's in the emergency room, the inpatient setting, the ambulatory setting, we end the encounter. And this is where we share information and we assess understanding with an interactive dialogue with the assessment and plan. And weaving all of these 3 skill sets together are what we call the pearls of empathy, where we emphasize partnership, empathy, collaboration, legitimization, and sometimes apology for what patients and families may be going through as well. So again, this is the general outline of our workshop. And today we will focus more so on skill set 3. And I'll take the next slide, please. And again, skill set 3 is how we end the encounter. I will pause here and turn things over to Christina to discuss a little bit about skill set 3.
Thank you, Abba. Can everybody hear me okay? Okay, perfect. So, you know, we want to just imagine how we end our encounters. And, you know, there's so many different ways we have encounters in today's society, whether that's in person, via telemedicine, via Zoom, via the phone, via patient messaging, through the electronic medical records, so many different ways that we can have different interactions with patients. So what we're going to talk about next is just how to make sure that we're all on the same page as we close out an encounter. And how do we make sure that everybody in the room has a voice and that we're making a decision as a group and not just a paternalistic physician telling patient what they need to do. We can go to the next slide. So we, as we end the encounter, we want to make sure that we're orienting and asking permission to begin the discussion. So that could be as simple as, in my day-to-day practice, I routinely see teenagers, and once we do a physical exam, I let the patients change, and then I bring parents and the teenager all back together. And as I enter the room, I just say a quick verbal cue, such as, you know, I'd like to go over my plan and the next steps. Is that okay with you? And so that's a signal that the visit and the appointment is coming to a close, and that we're going to be giving them some action items to go over. We want to make sure that we're using simple and clear language. We want to make sure that we're using pictures and models. So, for example, I have within reach, because I do telemedicine from where I'm located at, both a chart of different contraception options, and then different contraception IUDs, and a pill pack that I can usually reach quite handily. So those help me assist and present information clearly to the best that I can. And then avoiding any kind of jargon, meaning, so like instead of saying IUD, 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 we could say the contraceptive, the prevention of pregnancy device that's a little T that goes inside the uterus. So that's a descriptive way to describe it. And then if they're going to use that language to talk to their girlfriends or talk to their mom, they can share that information as well. I break down words like uterus and say that's the organ of the body where the baby will grow when you decide, or if you decide to have a baby someday. We can go to the next slide. So we're going to use an example that's outside of our day-to-day work comfort zone. So I'd like you all to imagine you're with your son or your daughter, and you have a high school soccer player who presents to the pediatrician's office with knee pain. And the physician or the provider comes back and says, you know, after hearing your story and doing the exam, it looks like your knee pain is due to a problem commonly known as runner's knee. I don't think it is a tear that will ruin your soccer season as you had feared. And then we can go to the next slide, and the provider continues. With runner's knee, which is actually termed patellofemoral syndrome, there are several things that I need you to do. The main thing is to stop doing activities that cause pain and switch to low stress activities like biking or swimming. I also recommend RICE therapy, which stands for rest, ice compression, and elevation. You should also take things like NSAIDs, which like ibuprofen, to reduce inflammation and reduce pain. It's really a very common problem. I think it will get better with those easy steps. What questions do you have? So that's not our day-to-day obstetrics or gynecology or newborn care. So we'll pause there, and we're going to go to the next slide. We don't want to overwhelm the chat box, so I'd like for people who have birthdays in February to write down just one or two words or what kind of you heard from the overall download of information that physician would have just given you about patellofemoral syndrome and the runner's knee. And I'll just pause here for just a few seconds and let's expand it out for a birthday in January, February, or March. All right, so I've got some answers of RICE, decrease your activity to low impact. I need to stop doing what I'm going to enjoy. Just kind of runners, that there's not a tear. And then one person says that they just heard the name of the syndrome and started worrying about how that would affect what they would do in the future. And I appreciate Alicia's comment. I heard really big words. And then RICE, rest and ice. So just some of the information, but maybe not all of the information. And you know, we intentionally chose a topic that's outside of maternal and newborn health to highlight what physicians or providers can give as a download of information or a recitation of what they see day in and day out. when the material is unfamiliar. And it's common for physicians and nurses and providers to get into that habit of, this is what they know, this is what needs to be done, and they just go through it because they've got 4 other patients to see before they can go home, and they're already 10 minutes behind, and they're just thinking, okay, we just got to get this information through, and good, we'll move on. And so and we can go down to the next slide. So how do we know the difference between a dialogue and a monologue? We want to ensure, using the analogy of a pineapple, that we're not going to eat a pineapple all at one time. You can try to eat a pineapple at one time. I would say it would hurt your belly. But we want to be able to break down the pineapple into different chunks. Check and make sure that that information is received, and then check back with the patient. That overall ensures simplicity, and it maximizes adherence if the patients and the family can really break down the information and process it as you go through it. Now, how you figure out what is the right size for the patient and the family, that's part of the trick. And so I'm going to toss the presentation to Tasha to go over how best to do that.
Thank you, Christina. So before I go into the art loops, we're going to take a bit of a pause just to see if there are any questions regarding some of our conversations so far, and then we'll go into those art loops. The one thing I do want to say is I noticed on this one, Maria said, am I supposed to put rice on my knee? And as we're going into those monologues, that's what tends to happen. She heard rice and knee, and that was it. If you have any questions, you can feel free to put them in the chat, and then we'll help answer any that we potentially can before we go into those art loops.
And just noticing some other comments in the chat. Someone commented, I have a 17-year-old high school soccer player. She would be panicking. I would have to talk her down. So many wonderful comments. I'd stop at patellofemoral syndrome, focus on looking it up when I get home. I think a lot of really meaningful statements here.
So there's one question from Alex, if you want to take this one, Abba. How do you manage to get providers time for training?
I can speak specifically for TCH. And I know we have colleagues across the country that have their own variation of the ACH curriculum. So I will acknowledge that the original workshop is about 8 hours, but we were able to find some ways to streamline the process, and we have a 5.5 hour that begins about 7:30, and if I'm doing the math correctly, ends just about 1 o'clock in our setting, and allows providers to also have a half day of work, potentially, depending on how their schedules are. But the simple statement is it's really supported by the organization and the institution. And it's been encouraged that everyone who is part of the organization take the opportunity to participate in the workshop. I hope that answers the question.
It does look like there was one other about working with learners, if you guys don't mind answering that. It was, have you worked with residents? And if so, how did you get this embedded into their rotations and their education?
So that's another great question. So again, when we started in 2016, the goal was just to focus on certain groups. And I acknowledge that the primary group was first the physician providers that were non-trainees. And over time, as we found our footing, we've been able to facilitate the workshop in different settings. For example, in July, new groups of residents, new groups of fellows. We've worked with our medical students as well at Baylor College of Medicine. And we've done a variety of creative ways. Like I mentioned, our curriculum is 5.5 hours. For our ambulatory OBGYN practice, we divided it in a series of 1 hour sessions. So we focused on skill set 1 for an hour, one week, and then a week later we did skill set 2. So we've had very different and diverse permutations of how we can divide the material. Like today is the first time that we are focusing specifically on the ending the encounter, and we'll take that back and perhaps utilize it in a different way as well. So I think we've been creative and we continue to learn and take the feedback from our participants. We take any other questions?
As we wait to see if there are any additional questions, I can give you a nursing perspective also from Texas Children's. So know that while we're training the providers, we've also started to include our nursing staff as well, so that we're all communicating exactly the same as we have patient encounters. And so we started with what is called Lunch and Learns for some of our leaders, and it's a condensed 1.5-hour session. But they have the ability to attend the full session. And so we're working towards getting that realm out to all of our nursing staff as well. So as you guys partner with nurses throughout the organization, we are all speaking and saying the same thing.
Can I ask you guys a question? I was going to say, do you find that people are more or less receptive at any particular time in their experience? In other words, I could imagine, you know, folks where they're really earlier in training might be very hungry and malleable and adaptive. I also imagine, like, it was extremely meaningful to me, and I had been practicing for a long time. And you've had so many patient experiences where, you know, things didn't go quite the way they should have, or patients didn't take away the information. And so I think you also could be even more receptive after you've been communicating with patients and had experiences that you had to improve from more. So any experience with if there's a kind of a more optimal time in somebody's medical experience to go through a training, or at any point?
I'm happy to take that, and then please team chime in as well. I think it's at any point. You know, we have had some colleagues come to the session with a particular concern, or maybe something that is ongoing, and hoping for some insight. And again, because of the nature of the group feedback, we are literally, this is pre-COVID, sitting in a room together with a group of maybe 10 or 12 small groups, and really sharing experiences and giving feedback. And that's where sometimes the demos and the role play are what a colleague is living. Like, this is the example, that this is where I'm struggling. This is a challenging patient encounter. This is someone who I have admitted upstairs on the floor. And that's where we talk through and have the opportunity to address those concerns. And then to your point, Dr. Epps, I think those who are new to their careers or at different phases are also always very eager to acquire new tools and skills. What are your thoughts, Fumi, Tasha, Christina?
We haven't specifically looked at that as far as the pre versus the post, as far as I'm aware of. My idea is that it is probably most appropriate after you've had some patient experiences. So like a medical student, not really giving, I would almost say a medical student might be too early, but during residency, kind of midway through the residency, where, you know, they've definitely had a lot of experience, they may be feeling burned out, that would be maybe a really good time. And then, you know, we also frame the day of the didactics course and the overall course in a way that, you know, we don't expect people to remember everything. It's not, you're not going to be proficient with all of the different techniques from the beginning, but if you go into it with the thought, well, maybe I can pick up 1 to 2 different things to focus on, I think that's where the real difference is made. Just trying to pick up a little bit at a time.
And I certainly agree. I think when you think about if you go back to the beginning of the presentation, and we talked about this being a procedure and how we have limited training and communication, I think it needs to be repetitive. And so whether we start at the beginning of kind of their course, or the beginning of their learning, and then add it in again and again, because in order to master something, you're going to have to do it over and over and over again. And so I think it would be beneficial to add, and I'm speaking for nurses as they're in nursing school, learning how to communicate with patients once they've graduated. And then as senior nurses or as new nurses, I think they need it on multiple occasions so that it does become a known procedure and they know how to communicate with both patients, families, but providers as well. So.
Do you guys feel like you have time for one more question? There was something from Jamie Morgan, who of course I'm going to pull out and ask her question. She asked, do you have any data about longitudinal follow-up after the course to see about skill retention and or how it changes provider patient perspectives or interactions in the long run? And I was gonna say, even if it's not data, any folks telling you about experiences, although you very well might have data.
Definitely some anecdotal experiences, but we are in the midst of working through that. I think we've continued to steadily ramp up, and we've done the 3, 6, and 12-month surveys, which have demonstrated overall increased comfort level and with the skills that are taught. But what we've realized is that there really is a need for a refresher, whether it's like the lunch and learns, whether it's an institutional email, because we are getting to the point where there's a significant portion of our team members who have had the initial training, and now we're going to continue with the next steps. And as we indicated on that timeline, now we have more facilitators. We started off with 12, and now we have 8, and we're looking towards those next steps, and maybe next year we'll be able to share some of that data as we wade through it. I would say that anecdotally, though, the feedback is very positive, that there is a level of retention. And like Christina said, not all the material, but there is something that sticks for everyone that's been able to participate in the course. Thank you for these wonderful questions in the chat. And please keep them coming, and we'll turn things over back to Tasha, who will tell us a little bit about the art loops.
All right, and so as we talk a little bit about the art loops, we're going to talk about exactly what they are, and you can hit the buttons. I think there's going to be 3 bullet points on this one. And what it really is, as you know, we have an acronym for almost everything. And this one is really asking for the patient and family's perspective. And that really is trying to meet them where they are, get a clear understanding of what the family's awareness is of the conversation or the instructions that you're about to give. Reflect and respond with empathy. And so part of that requires reflective listening. Kind of understanding what the family is saying so that you can respond with empathy, and then tell and teach your perspective, making sure that you guys are on the same page prior to discharge or admission, prior to the next visit. We just want to make sure that we, one, have level set and have had a conversation with the families and met them where they are, respond with that information, and then begin to teach. Next slide. And so I like to call, in the middle of our art loops, the way in which we do this is to act. We assess an understanding, collaborate on plans, including assessing some of the barriers, and teach back. And so even though this method in and of itself may take a little bit longer, it is helpful in the long run and can reduce some long-term issues or kind of those doorknob questions. Patients tend to come away with a better and informed understanding than when they entered. And that's really our point. That's really our goal, is to make sure that they have an overall awareness of either the disease process or the discharge instructions, or what you would like them to do. And then discover what the patient, it helps discover what the patients already know. And so if you assess the understanding and meet them where they are, you can have a conversation about what it is they know, and what you need to teach. And so that's very helpful kind of in the long run. We don't want to go in and assume that there's already this kind of knowledge base. It saves you a lot of time in the long run, but it can be or can feel lengthy as you're starting to do this. And then it can alleviate some of the non-adherence. If I don't understand what it is you want me to do, the likelihood of me doing it is pretty low. And so we want to make sure that there's an understanding of appointments and what messages. I will tell you, the first time someone gave me my chart, I played around with it for a while, and never did I realize that there were kind of written instructions and how to go through it. And so as you begin to do some of your art loops and some of your teaching, at the end of that, just making sure during that teach back, you have a clear understanding of what they understand and the interpretation of what you said. Next slide. And so in those art loops, so we're gonna go back to the example that Christina talked about, and it was the 17-year-old high school soccer player who presented to her pediatrician's office with knee pain. And so she's now diagnosed with runner's knee. Next slide. And so in your art loop, what you want to do is really ask, have you heard about runner's knee? What do you know about runner's knee? For someone who may have never had an injury before, they may tell you that they know nothing about it. Others may have had this injury before and kind of are up to date and know exactly what to do. And so this is the part where you're asking for their understanding, but really asking where their level is, their level of understanding and what it is that you need to do. Next bullet point. And so reflect. It sounds like your friend has had a difficult time with her recovery. I'm so sorry to hear she isn't playing. And so people will come in with kind of perceptions, right? We know that Google is out there and a lot of things are on the internet, and they'll tell you kind of this is what you're supposed to do. And so for this particular case, if the friend had the same knee injury, it is very good to let someone know that it may not be the same healing process for you, but again, we're meeting them where they are. So for this particular person, their understanding of runner's knee came from a friend. And so in your reflective listening, you would just say that it sounds like your friend had a difficult time with her recovery. I'm sorry to hear she isn't playing anymore. Next slide, or next bullet, I'm sorry. And then the teach back. I think you're going to have more success with your recovery. I'm going to recommend rice therapy. And as several of my colleagues mentioned, we want to make sure that we spell out what rice therapy is. Similar to in the hospital, we want to try to avoid some of that jargon. So you don't want to say NPO, you want to say nothing by mouth. You don't want to say just rice therapy. You want to talk about the rest, the ice, the compression, and the elevation, but then the other piece of that is how long. So for just in the chat, someone thought they would put rice on their knee, or you want to make sure that you're clear on how long to leave ice on the knee. Just making sure that the compliance is there. If I don't know that it's only supposed to be 15 to 20 minutes and I leave it on all day, the next day I probably won't do that again because that doesn't feel so good. And so we have the tendency for non-compliance when we're not clear with our communication. Next slide. And again, you want to ask, have you heard of rice before? And this is where you want to explain all of that information in regards to rice therapy. Next slide. And so the other thing you want to do is summarize and clarify with the teach back. And so you want to make sure that as you're talking about the rice therapy, your patient may ask you, do you want me to keep the ice on all day? And so you want to be very clear and concise that you want to keep that ice on for 10 to 15 minutes at a time, but frame your diagnosis and your treatment. Revisit the patient or the patient or the parent's original concern. What was their original concern? Can I play again? Do I have to keep this on all day? You want to make sure that you're touching base on all of those items prior to leaving, and then use simple and clear language. And as Christina mentioned early, make sure that you're using pictures or models or anything that they can relate to in order to help facilitate some of that adherence to the instructions. It helps to present the information as clearly as possible. If possible, use the patient's words. If rest to them means lay down, then I want you to try to lay down as much as possible. Rest for me is very different. If I'm sitting in a chair, I'm resting because I'm always moving. If you want me to elevate, then you may need to say lay down and elevate your leg. And so you want to make sure that they are clear in regards to what you mean by rest and what you mean by elevate and what you mean by ice and those types of things. Next slide. And so another helpful thing in the teach back process is how we close this out. And so you really want to ask them or let them know that you've done a lot of talking. You've given them some information, and this is kind of that chunk and check added into those art loops and trying to avoid monologues and going into dialogues. And so for me, if someone is caring for that patient when they get home, tell me what you would tell your dad if he was taking care of you or if he was helping you. Allow them the ability to recite that information back to you in their own words so that you can assess their knowledge base and their information and assess the fact that they have received all of the information that you have given them. And when they respond, make sure that you're actively listening to ensure that they have the correct information. And if they don't, make sure that you have the ability to add in and teach some more. And so as this kind of highlights, you ask the patient and the family to summarize, and then you respond. And then if it's correct, then yes, those are the important parts of the plan. And then you can teach additional points as needed. And so to avoid kind of going into the monologue, we allow some chunks and checks. You give them some information. You allow them to give it back to you. You respond in kind. And then we start again and give some more information. Next slide. And so now I'm going to hand this over to Christina to walk us through an exercise.
So this is a quick exercise. We all have different day-to-day patients that we see or different encounters that we have throughout the day. And so hopefully throughout the past couple of minutes that we've been talking, you've been thinking, well, how does this apply to me in my day-to-day routine? So I'd like you to just take a moment. You can close your eyes. If you have a piece of paper handy, that's awesome. I'd like you to just reflect on a common topic that you counsel patients on all the time. It's something that you can recite by memory. And if you're thinking it through, can you identify a few key points, maybe 3 key points that you could further break down into an art loop or an ask, reflect, and teach loop? And then you can just write those down. You don't have to share them in the chat. This is just for your own personal reflection. And while you're thinking of yours and you're writing down, one that comes to mind for me is to discuss polycystic ovarian syndrome, which is also abbreviated PCOS. And it's also known as, if you break it down outside of the term, which is really a bad term, elevated testosterone in a patient with irregular periods. And so that's something that I counsel teenagers and young adults on multiple times a day. And so going through this reflective exercise really helped me break it down into the different parts and just opening up the discussion by saying, what have you heard about this syndrome? What does this mean to you? And a lot of patients have already either been diagnosed with it in the past, like their parents have been diagnosed with it, or they have friends that have it, and they either have some good basic information or they have some misperceptions. And so being able to modify the next things that I say based on what they tell me tends to be really helpful. So we will now, I think we can spend, after you've thought about that, we're going to spend some time with a different possible information download that may be familiar to many. And we're going to, many of us here, and then so we're going to go over how we discharge a new mother from the hospital. Fumi?
Thank you. So in this demo, I'll be going through a prided spiel. I think as clinicians and providers, we often pride ourselves in our ability to say lots of things in the quickest time and get out the room as soon as possible. And that's the goal, or previously our goal. With this new concept, our goal will be different. But as you're listening through this, this is a classic discharge. And as I mentioned it, you can just identify the points that are being made. Just a few last instructions before we send you home today. Make sure you keep your cesarean section incision clean and dry. No tub baths, but after you shower, just pat it dry and make sure it's really dry. Let us know if your incision turns red or if you notice any painful or oozing areas. I just want to go over some other reasons that you would need to return to the hospital or contact our office. If you have a fever of 100.4 or having difficulty breathing or feel like you'll pass out, you also want to watch out for swelling of your legs or pain behind your calf, because these are signs of like a deep vein thrombosis, which could lead to pulmonary embolism. Also, if your bleeding is really heavy, specifically greater than 1 pad an hour for more than an hour in a row. And then lastly, because you had preeclampsia, there are some additional things to watch out for as you go home. Severe pain in the eyes, changes in vision, elevated blood pressure, or even a severe headache, like the worst headache of your life, shortness of breath, and or right upper quadrant pain. We also want you to take your blood pressure daily. Let us know if your blood pressure is above 140 for the top number or 90 for the bottom number. I know you're still waiting for your blood pressure cuff to arrive by mail next week. So maybe it'll be good for you to pop into Walgreens twice a day to check your blood pressure, because it's very important that we monitor that over the next few days. And then we'll see you back in the office to recheck that blood pressure in 7 days. Okay, so let us know if you develop any pain, tenderness while breastfeeding. Be sure the baby sleeps in a separate crib, and careful that you don't fall asleep while breastfeeding. Baby should always be back to sleep. The pediatrician will go over how to take care of the baby, circumcision, and remember, pelvic rest, no heavy lifting for 6 weeks. Any questions? Congratulations again.
We see those reactions, lots of reactions. And, you know, the information is there and it's important. And how often is this the sort of discharge that we give and get, because we're rounding and there are patients that need to be seen. And again, we're using this example. This really is applicable to all aspects of the medical setting, the healthcare setting, and outside as well in day-to-day life. So we'll take the next slide. And as promised, this is our demo. So let's demonstrate incorporation of some of those skills that we've mentioned, which we're going to focus on the dialogue versus the monologue. And that's that pineapple, where we are breaking information into digestible pieces. And it's not that download of the whole pineapple. And then the art loops and the shared decision making. So those are the 3 focal points. And let's try and do a rewind and a redo of the postpartum discharge summary. And again, we won't do the whole. We're just going to take a small aspect of it and just run a demo. And these are the sorts of demos and role plays that we do, that we discussed in the workshop. So I'll pause and my 3 colleagues will facilitate and intro the demo.
All right, so for our demo, I'm gonna be the provider, and I'm gonna be talking to my patient, Mrs. Bush, and I've been taking care of her for many weeks now. So we have a report already set up. All right, Mrs. Bush. So we have covered caring for your baby girl, but we need to also talk about making sure that you are healthy. Do you have time, and can we talk about that?
Sure.
All right. Well, what are some things you think you need to do?
Well, I need to make sure I drink enough water, and I hope I get to sleep.
Yeah, those are some great things, and we definitely want you to be drinking enough water and getting some sleep when you can. Now, because your blood pressure was really high while you were pregnant, we also want you to check your blood pressure. How do you think you could do this at home?
Well, I've seen the nurses, they've done it a lot, so I think I can do it at home, just as long as someone shows me how.
Yeah, awesome. Well, our nursing staff will be able to review the placement on your arm and how you should be sitting when you take your blood pressure and kind of just some general guidelines. Now, sometimes patients have a blood pressure cuff at home or a family member has one. Would you have access to one at home?
Yes, my husband has one.
Great. So, well, please make sure that you have batteries in it that are working as well. Sometimes, it doesn't get used and batteries can go bad. The other thing is it's quite important. Can you write down the numbers twice a day and tell us if they are elevated? Do you know what kind of numbers we need to know about?
Maybe like 138 and 68. That is what my blood pressure was the last time.
Okay, well, that's pretty close because your numbers have become more normal since you gave birth. The top number should be under 140 and the lower one should be under 90. And we need you to call the office if those numbers are above 140 or above 90. Those would mean that your blood pressure has now become higher than it was when you were in the office. We also, here is a log, and so you can write down the numbers.
Okay.
Okay. Now, you've also stated that your husband would assist you with this, and I know he's been here and he's not in the room right now. Is that correct, that he's going to be helping at home?
He is going to be helping at home.
Awesome. So we have tackled so much information, and I want you to want to work together with your family toward your well-being. Hopefully, your husband will be taking care of you as you are taking care of the baby. What instructions can you help him give, understanding what you will need? Can you tell me how you might explain what I've gone over in the past few minutes to him?
Sure. So I would probably tell him that I need to take my blood pressure every day. I have to write it down in the log that you gave me. And if that top number is above 140 or the bottom number is above 90, then I need to call the office. Is that right?
That is so close. You get an A. To just increase it to an A+, I'd increase taking the blood pressure to 2 times a day. But otherwise, your numbers were on target, and I think you're going to do a great job. What questions do you have?
No questions.
All right, thank you. And at this point during our role plays, we would say kind of a timeout, and we would debrief it, and we're going to have Fumi debrief our role play we just did.
Thank you so much, Christina and Tasha. That seemed so natural, wasn't at all fictional. But like we said, typically in our workshops, we usually have this opportunity to debrief and kind of discuss back and forth. Unfortunately, in this setting, we can't have that kind of discussion back and forth, but feel free to make comments in the chat box. I wonder how different that felt watching that interaction versus my initial download. A few things you'd have noticed right off the bat is that it was a dialogue. It went back and forth between the provider and the patient in this scenario. And then I wonder if you guys can count how many art loops Christina so skillfully pulled off and incorporated into that discharge. We typically also time our sessions, and I kind of jumped on it a little late, but I was able to time out that whole conversation at 3 minutes, 19 seconds. I'll add, maybe 4 minutes, but all of that conversation, all that interaction happened in less than 4 minutes. And for a patient or a family member receiving that information, being able to get it in those small amounts allows for better retention, and better retention just allows for improved compliance. So I heard the lovely opening that she did. Christina kind of said, hey, we're here ready to talk about your discharge. Is this a good time? And just kind of setting the stage right off the bat, level setting, allowing the family to pay attention to what's coming next, right? Sometimes we're distracted on our phone or we're doing other things. And so I heard that, Christina, that was fantastic. And then really a few art loops skillfully inserted in there. There was one that was talking about what information did she know? Did the mom already know about what was expected of her? There was one specifically about the blood pressure and having access to it and being able to use it. There was one specifically about what was required as far as how high, how many times to write it down. And then there was instruction, the opportunity to teach that information or assess her understanding of everything altogether by asking her to relay, what information would you tell your husband about what we've talked about? How would you help him understand what we spoke about in this session? So those were 4, at least, art loops that we were able to count in that encounter, and so skillfully woven in there. In addition to those loops was her empathic statement that said, an A+, you did great. You know, you gave me most of the information, and she inserted just an added component of the teaching to fill that little gap that was left, and then encourage the mom, you will do great at home. I think you have everything you need. And so when we're talking about this communication style, it really is that art of breaking it up into pieces, reframing it in a way that the patient or the parent can understand, and then sealing it with those empathic statements, whether it's empowering them, legitimizing their concerns, or whatever that conversation calls for. I'd love the opportunity to look through the chat box to see. There was a comment here. It says, like, feels like a relationship functional conversation takes more time for the nurse, and I wonder if nurses will take the time to do it in all aspects of your discharge instructions. We found that when we were looking at research studies, as far as the length of time, this component of it may take longer, but in the overall communication and overall encounter with the patient, it actually decreased time. And so we made it a point just to keep track of our time, because oftentimes it feels like it's a lot longer than it actually is. And you can get a meaningful conversation in 2 to 3 minutes. Somebody else put here, it reminds me of a ping pong game. Everybody gets the chance to interact. I love that.
And sometimes there may, just to, piggyback from that, there may be certain topics that are very, very crucial. And those points that, you really want to make sure are well taught and well emphasized may be the focal point of the art loops. And because sometimes, again, acknowledging what Fumi said, overall, we have found that this taking a little bit more time at the front side decreases time in the long run. But making sure that we really utilize the art loops for those most important topics and takeaways.
Thank you, Abba. We can go to the next slide. And so in this discharging of mom from postpartum, there are different components. So the exercise we discussed earlier where it says, could you identify areas and kind of break them up? So care of the newborn, postpartum hypertension is kind of what this demo demonstrated, but you would probably separate a different one for the wound care, and then, of course, next steps. Next slide. And so as part of the close of the encounter, identifying those teachable points for the families is important, but then also clarifying their next steps. What is needed for them, when they should be communicating, appointments, things of that nature. Also included in that close of encounters, any further questions that they may have that we didn't foresee or didn't address. And then really sealing that encounter, like we said, as Christina did in the demo, just empowering the family, legitimizing them, supporting them, comments such as, it's been a pleasure to meet you, to work with you, we look forward to seeing you again, things of those nature that allows them to feel a part of the team and puts that personal touch on that communication. Next slide, please. And so I'll pass it back to, take a pause there and send it back to Abba to close us out.
Absolutely. And, just to summarize, I won't ask us to necessarily scroll back to that slide again, but the takeaways, if you can remember that little pineapple, because that is, for me, that was one of the most easy to understand takeaways. We think of the pineapple, and it sounds funny, but if you go to the grocery store, you'll see pineapple in slices, in chunks, tidbits, crushed juice. So sometimes you just need to really figure out the extent of information that you can give and continue breaking it down. So I really like that analogy, and that can be one tool that you take with you. Just make it small, digestible pieces. What is the amount of information to give? Again, it's based on the patient and the family's perspective. I've also heard sometimes in our sessions that sometimes when we're working with an interpreter or a translator, somehow we know just about the right amount of information to give. And it doesn't necessarily stand across all examples, but many times that's about the right amount of information. So that's point number one, the downloads, just avoiding the downloads and making the information small and digestible. And then the art loops, the asking, the reflecting, and the teaching. And slowly those become integrated, and you may develop your own art loops, as Christina asked you to reflect on. And when we have those tools in place, that leads seamlessly to the next step, which is that shared decision making and compromise and dialogue and negotiation of the next steps. So I will just review the summary. Communication matters in the healthcare setting, and I will say outside of the healthcare setting as well, communication serves as the foundation for shared decision making and best outcomes. And like any procedure, we can continue to improve our skills in communication. It does require work, openness, and acceptance to feedback, and a dedication to improvement. And an RCC communication model is one of those frameworks that have been demonstrated to be effective for these goals. I do think there may be a few questions in the chat, so let's see. Let's go back.
And perhaps we need to put up the acknowledgements.
Yes.
Slide.
Absolutely. We can go ahead and go to the next slide too while we answer those questions. So the next slide is acknowledging all of those people that have made this possible. So TCHMB, thank you very much for the honor and opportunity to join you today. Academy of Communication in Healthcare, Texas Children's, the Texas Children's Breakthrough Communication Team, co-trainers and co-faculty in training, and then our respective departments at Baylor and OBGYN and pediatrics. And it looks like we're about 10 minutes ahead, but hopefully we have some additional questions that we can take time to answer.
But one of the things that I saw was folks commenting about this was very verbally focused, and certainly some people learn better visually. So I wanted to ask if you do anything to adapt your communication based on someone's learning preference, or how the same techniques might be able to be represented visually, and if you had any thoughts about that.
Absolutely, and I'm happy to answer that. So pre-COVID, in the typical format for this workshop, there are several visual cues, and again, this is a unique platform that we've adapted to be able to work through Zoom, but everything is visual as well. And the focal point is less talking. We've done more talking in this session than we ever would have done. It's really a conversation, and around the room that we're at, there are visual cues. There's a card that demonstrates what these art loops mean and sound like. So I think there's always room for continued improvement for different learning styles. I do think that the workshop in its normal state pre-COVID does take into consideration and really does work to incorporate some of the specifics for visual learning as well. Christina is showing us this is one of the placards that we distribute, and really the didactics are a minimal part, and so much of the learning comes from the conversations. We make a list, we write a real-time list of concerns, those topics that have been concerns for you as a provider or a member of the healthcare team or the medical team. And that's what fosters the dialogue.
One of the other, and there's just so many comments about how wonderful this presentation is and how much it illustrates. Somebody used the example of discharge information being like taking in a fire hose. One of the things that I noticed is you asked permission. And certainly in the realm of like motivational interviewing and something I learned with counseling people about COVID vaccination, how important it is to ask permission. I wanted to see if any of you have any, if you can explain why you ask permission as the beginning to this, and then what you might do if somebody, isn't ready to receive information, how you adapt.
I'd love to take that. I work in the emergency center, and so the assumption oftentimes is that they're always ready. And we walk in the room, it's kind of, I have the answers for you. You came here for answers. Let me give it to you. But having asked that question, and when you do, right now, especially in this scenario where not everybody is allowed in the space or can be in the space that participates in the care of the child, you'll have families who'll say, well, give me a moment, let me get grandma on the line, or give me a moment. So it allows you, and it really does, it has shortened for me discharge instructions, because when I fail to ask, I'll inevitably get to the end and then they'll say, oh, my husband also wanted, do you mind saying it again to him? And I'll have to repeat myself. So the asking, one, shows respect, right? And it also allows that family to get in the frame of mind to receive information. And then, like we alluded to before, it facilitates everybody that needs to hearing it at the same time. And it brings all those questions. So I have had scenarios where they're not ready, or they're on the other phone, or a child is being, my other kid needs to go to the bathroom and I'll be back. And so it's like, sure, I'll come back, because we also want to optimize our time and not give information when they're not able to receive it, or there are other distractors. I'm not so much in the virtual platform, but I have had colleagues who say, even in a virtual space, when you're doing a virtual visit, there are oftentimes more distractions in their environment. And so asking that gets their attention, and so they can focus on what's going on with the visit and be less consumed with the environment, or less opportunities to be distracted.
Someone has asked how you might respond if the mom said, and I think this is probably for Christina, if she said she didn't have a blood pressure cuff. And I was just gonna say, this is something I learned so much during COVID, where I had this like scripted, I'm gonna tell you what the CDC says you're supposed to do when you go home, and then realized it was just total junk on my behalf, because it was not in any way something that many, like I would tell people, you need to go home and isolate. Well, they're the healthiest person in their house full of people that they're in charge of caring for. That just wasn't reasonable. So then kind of adapting based on how they responded. So if she had said she didn't have a blood pressure cuff, what would that dynamic have looked like?
Yeah, so that's something we actually talked about using, because, if you say it, you can say the words, but is that realistic? I mean, that's just not, it's just not very realistic. And so I would use more of a motivational interviewing, if they don't have a blood pressure cuff, work through problem solving with the patient. So say they didn't have one at home. Do you happen, how do you think you might be able to get a blood pressure cuff? And if they look at you with just a blank face, you could say, do you have any family members? Is it possible to borrow? And then if they do think they might be able to make it to Walgreens twice a day, which I don't think is reasonable for anybody with a car, without a car, any way, shape, or form to really realistically think you can do that. Ask what barriers they have. I think that's a really revealing question, to ask what barriers do you think you have and how do you think we could overcome those together?
I think one of the other things that's very helpful is that we can utilize the resources here, right? So we have social work, care coordination, and sometimes we have to call on our colleagues to kind of help and formulate a plan to get them a blood pressure cuff. We often find that in the emergency center. Funmi will say, Tasha, I need you to discharge this patient, and this patient needs crutches, et cetera, et cetera. And so we have to kind of engage some of our colleagues to kind of help get them all of the things that they need. I think when you talk about discharging someone safely, you want to make sure all aspects are covered, and that would probably be one of them. To make sure that they're discharged safely would be making sure that they have a blood pressure cuff or a plan in place to get these blood pressures twice a day.
I have one more thing to add. Also remembering that all of our patients are doing their best, and to come with the counseling from a place of empathy, remembering that our patients are trying to do the best for themselves and their babies with whatever limitations. And we may not be able to elicit all of those limitations, but remembering that they're trying to do their best.
Thank you so much for saying that. I was going to say, I think, this is transitioning out of the still focused very much on the patient-centered care with what you just said, but also making sure you might need to resource your setting differently. And I practice at Ben Taub and have learned it's just not realistic to tell people they need to go get a blood pressure cuff. So we buy them and we hand them out. And that was just a consistent barrier that we had run into because of things our patients were telling us. A lot of comments about loving the statement of coming from a place of empathy. Someone asked, do you encourage patients to Google some of the information already provided? I'm just going to add in, or do you have any other, do you direct them to certain places that have reasonable, like evidence-based, vetted material? And do you do that just in case they don't remember every instruction, or do you have another thing that you recommend in case they forget what you've told them?
I can take that one. Sorry.
Go ahead, please, Tasha.
We discharge a lot of patients out of the emergency center, and so we have obviously the AVS, but we try to meet regularly so we can update credible sites. So if there is a discharge that is listed on the AVS, the instructions are there, but also some credible sites that they can visit should they want more information, especially in this COVID era. If they're calling into our call center, et cetera, we have kind of the CDC information, but then we tend to look at all of those pre-populated scriptings for our discharge instructions and update some of that information. I don't know that I would encourage just random Google searches, but ensuring that there's credible information that they can find should they want to research it a little more.
Abba, were you going to add something to that?
Very similar, echoing what Tasha said. When each time we've been able to facilitate, we get a lot of great feedback from our participants, and some, as they create the AVS, have also used that as a form of the art loop. So, I'm typing your after visit instructions. What should I put on here has been, a phrase, because then we're also hearing the patients repeat it, and then we're creating something that makes sense. And that is one idea that has come from some of the workshops, and then just utilizing those tools real time and utilizing hands-on demos. To circle back to the question about visual, this is also tactile. So if we're discussing a wound change, we actually do that at that time as well. And while doing that, you can still utilize those art loops as well.
I was going to ask if you guys have any strategies you recommend when a patient you're working with reflects back, or you ask them to, and you realize that they do not understand at all what you have explained to them. And I think that can happen for a variety of reasons. I have a colleague who always tells a story about having counseled a patient in ultrasound, and a baby had anencephaly, so doesn't have a calvarium, a horrible diagnosis. And she had brought in a translator, and so it very much was like a data dump. And at the end, the patient just said in Spanish, "Is this bad?" Meaning totally did not understand the very long dialogue that they just had, which, you know, she uses as an example of a total failure of counseling and not enough stopping and doing the art loop and all the things that you guys say. But what about when you realize that there's just such a huge gap between what you have explained and what the patient understands? What are strategies you use to readjust?
My biggest strategy has been to take ownership for that failure and just to say, oftentimes I think I've been clear and I apologize if I have not been. Would you give me the opportunity to clarify again? And not assume that they didn't hear well, but to assume then and take ownership for my failure to convey the information correctly and to ask for the opportunity to reconvey that. And typically they're open. And then based on what they said, there's the opportunity to either identify one true factor and build from that. And like Abba had commented, yes, some people can take pineapple in chunks, some require pureed, some need it juiced. So it really allows you to determine how best to dissect the information for the family or the patient to receive it.
What fantastic teachers and listeners you guys are. So thank you so much for all of your very thoughtful responses. There have been some comments about the value of having somebody available 24/7 as people have ongoing questions. I was going to ask, do you guys do any specific training with groups like, she's using the phrase "ask my nurse," which is something our healthcare system uses also, but it's kind of like the 24-hour if patients call in. That is like 100% their job. Have you had any experience with those telephone groups, and any tips on working with them if you have?
Oddly enough, I'm the director of the EC call center. And so that is the telephone group who is on 24/7 to take those calls. And so we've done kind of some variations of this training to help them kind of do reflective listening. When you think about their job in general, there's one person at a time in there, and the line is going multiple times. So they're trying to kind of get that information out as quickly as possible so they can get to the next call. And so we've kind of worked through how you deliver that information and that feedback, and how you reflectively listen. There's sometimes that they're going to have to send folks to the emergency center because what they're calling about is emergent, and then some we're going to have to kind of redo the information. And so they have access to all of the charts, and sometimes they have to spend some time going through that AVS and reiterating that that information, and then sending messages to the providers for the next day to kind of call the families back. And so it's a little different. It's a little different when you're on the phone, but we certainly work through that aspect. Our biggest key point is going to be kind of your chunks and checks and your reflective listening while you're on the telephone.
I was just reflecting as you said that how our Ask My Nurse group is literally the best group at receiving and adapting feedback that I've ever seen. And it's probably because of what you just described, and that's this integral part of their job. Cynthia's commenting, and she's a part of a number of initiatives, but including the Fetal and Infant Mortality Review for cases of congenital HIV or syphilis transmission. And so they review cases where babies have had transmission of HIV and syphilis for opportunities. And she was saying when she reviews cases, one of the things that they discover is moms didn't understand the severity of their and their infant's diagnosis or condition. So I wanted to see if you get that sense in what you're hearing back from them, how you adapt. And that's pretty complex because they just, people obviously cope in very different ways. And I have definitely earlier in my career felt like, all right, they're not understanding the severity of the diagnosis, and then you go too far and all of a sudden they're crying, and it's hard to, everybody adapts and hears differently, and their response might necessarily in that moment reflect what they're actually understanding. But how do you gauge if they are assessing if you're giving them serious news, whether they understand that or not? Or is there a different strategy other than that one conversation to make sure that happens?
I think that does circle back to that asking permission for that next part of the conversation. And it may be, just like you said, more than one conversation. And this is where we may consider employing a strategy such as asking, like, can we continue to talk more? Or can we continue the conversation? Or would you like us to? Or acknowledging that what we have shared is heavy and maybe weighted, and that really letting the patient and the family and the caregivers guide the direction of the conversation.
I echo what Abba just mentioned, and I'd also say that you can lean into the pauses, saying a verbal cue like, I just talked about some really big stuff or some really heavy stuff. I routinely talk about sexual assault and suicidality during my patient encounters, so those are pretty heavy for teenagers and for parents to hear. So I will often say, let me just pause there, let you take a moment, and you can let me know when you're ready to go on. And that pause can emphasize the importance of what we just talked about.
All right, I again want to thank you guys so much for such a wonderful session and such an important thing for all of us. And there are just so many really positive comments in the chat about how valuable your talk has been. So thank you so much. And now I am going to transition it over to Dr. Lakey. Thank you again.
Thank you, Dr. Epps. What a privilege to be part of this conversation today. Really great presentations. We really have a cross-section of the people that we need to work together to improve birth outcomes in the state of Texas. People that work in the hospitals, people work in the communities, nurses, physicians, community health workers, and even policymakers. And the policymakers, the members of the legislature that are here today, thank you for being part of this conversation. I have like 3 pages of notes in front of me that I have taken to help guide my thoughts in the future of how do we move forward. We started off today with data, and starting with the data and confronting where we really are related to birth outcomes, our infant mortality rate, our prematurity rate, our maternal morbidity and mortality rate, the disparities that are here in Texas. And we have to confront that and say that these aren't acceptable, that we really need to move forward. After starting with that conversation, I thought Dr. Deborah Bingham did a magnificent job and touched not only our minds with the data, but touched our hearts related to how important this is. Talking about the disparities, and that disparities can be invisible unless we measure them, and the need for data. Talking about the myths that we have that blame patients related to the outcomes versus confronting what do we do that may result in the outcomes that we see. Talking about the social determinants of health and that a lot of times we blame race, and it's actually racism, that it may be intentional or unintentional, but the differential treatment that we provide individuals that correlates to race can result in these outcomes that we see. We heard about the importance of quality improvement, that is the responsibility for all of us, that is not discretionary, that we have a 17-year lag between what we know we should do and what we're really doing. And that's why it's important for you to put these ideas into place, that the importance of implementation science and improvement models to move things forward. And that it's going to take committed leaders like you working in your hospitals, working in your communities to really move things forward. And that QI really saves lives. I am always confronted by the patient panels and what a magnificent job they do in making this real. So it's not just theoretical. And so the parents, that were part of the conversation today, thank you so much for sharing your personal stories. And I can't imagine how hard that is to talk about some of the worst days of your life in front of a group like this, but it really does change how do we improve the systems. We heard about the transitions from pregnancy to the emergency department, to labor and delivery, to the NICU, to nursing care, and finally to the homes of individuals. And in their stories, patients shared a range of experiences. Some were extremely distressed and scary experiences, and others shared feeling incredibly blessed with the care that they received. We heard from a patient who experienced postpartum hypertension and felt failed by our medical system. We heard from a family with a 6-month NICU stay, and we heard from a healthcare provider who had to be her own best advocate to get the information and instructions that she needed. We heard about the challenges of parenting triplet NICU babies and the power of the whole family. We even heard and got to hear from a 14-year-old named Shauna, and were inspired by her enthusiasm and passion for biology and creative writing. And we truly appreciate all of our patients, panels, and their family members who shared their very personal experiences. And as one of the conference attendees commented, each story was incredibly impactful, and your willingness to share will benefit so many families. And then in this final presentation, we heard of the importance of shared decision-making with our patients, that the relationship-centered communication really is important, and the value of empathy as we are in any of these clinical situations. And I heard the difference between a dialogue and a monologue and the simplicity, and I love that pineapple analogy, and I will remember that. We heard of the value of specific training, of art loops, of asking for patients and the family's perspective, of reflecting with empathy, and to telling and teaching our perspective, of gaining that power after we've listened to our patients. And that discharge instructions that we heard, the 2 different ways to do that should open all of our eyes about what do we do as we send people home and how do we communicate. And that if we want better outputs, better outcomes, that we need to do better at communicating with individuals. So a lot of work has taken place to put this together. We have a lot of work to do together in the area of quality, healthcare equity, and specific race equity. And so a couple of things before we go home today. First, I again want to thank our speakers and the organizers of this event. If we could put up a couple of slides with my team, just a couple of folks I want to thank. And first, you need to know that there's a lot of people right now working really hard to make all this come together. And I am blessed with an amazing team that's downstairs that have been working all week, trying to make slides the way that they need to be, trying to make sure that people come into this meeting. It really is a tremendous group that I have the privilege of working with. And so I'm going to start off with just thanking these people that you have listed here, who, again, I am fortunate to work with day in and day out, that are tremendously dedicated to this mission. Next, I want to thank the Department of State Health Services to be the co-host of this. This wouldn't happen without the support of the Department of State Health Services. So thank you to the people involved in putting this together. And I want to thank our hosts and our sponsors. Again, our gold level sponsors that you see here and our silver sponsors that have been providing the funding in order to put all of this together, and again, are part of the team and are dedicated to our mission to improving the health of all mothers and all babies in the state of Texas. A couple of reminders that I have before we go home. First, please complete your post survey if you would like to receive continuing education credits. The post survey will be emailed to you at the conclusion of the second day of the summit, or tomorrow. We hope that you will complete the survey and let us know what you enjoyed about the summit, and let us know what we need to do better. Again, we bring quality improvement to the work that we do. And so if there's things that we need to do a little bit better, please let us know. I would also ask you to save the date of February 15th and 17th of 2023. for our 8th annual summit. Again, we need to continue to focus on this mission, and I would ask you to be part of that next year. We hope that you will join us tomorrow for day 2 of this summit. It starts at noon Central Standard Time. And tomorrow we will learn about some new services under the Healthy Texas Women's Program. We will learn how to incorporate the voices of patients and families impacted by disparities in quality improvement projects. And we will learn about quality improvement opportunities for postpartum preeclampsia and for critical congenital heart disease. I hope you're with us tomorrow. And again, I hope you have a great evening. Thank you for your time today. And please take these lessons we've learned and put them into practice. Thank you.